TopMedTalk.
Welcome to the World Congress of Perioperative Medicine, EBPOM 2021. This meeting and our mission to bring medical education to the world is made possible by you, as well as our generous sponsors. Thank you guys so much for your support. It's now time for our Medtronic-sponsored lunchtime session, TIVA, or Total IV Anesthesia versus Inhalation Anesthesia, the pros, the cons, and the benefits of processed EEG monitoring. I'm Desiree Chappell, co-chair of this meeting, managing editor of TopMedTalk, the broadcasting arm of EBPOM. First up, presenting the benefits of TIVA over inhalation anesthesia is Dr. Peter Roy Kikegaard. He's a senior consultant and medical staff specialist at the Department of Anesthesia and Intensive Care at the Nykoebing Falster Hospital at the University of Southern Denmark. And here from New York City to discuss inhalation anesthesia over TIVA, practical consideration and trends, is Assistant Professor of Anesthesia and Critical Care at Memorial Sloan Kettering Cancer Center, Dr. Anoushka Afonso. Hey, how are you guys doing? Thank you so much for joining us. Peter, tell us just quickly a little bit more about yourself.
I've been a specialist doctor for the last 15 years, and I have a lot of interest in, of course, patient-centered care, but also leaning the way we do stuff. The Danish healthcare system is mainly public, so the private sector is very small in Denmark, but even though we have to take care of the taxpayers' money, so I think to do efficient surgery, efficient anesthesia is very a central role in my daily clinical practice.
Anoushka, tell us just quickly a little bit more about you.
Okay, thank you, Desiree. My hat that I wear is also Director of Enhanced Recovery after surgery at Memorial Sloan Kettering, and this is for all our cancer patients, all the different service lines. So anything that we can do to expedite their recovery and oncological outcomes is, of course, appreciated and something that we're focusing on. So I think there's a lot of variations in practice around the country, around the world, that we're excited to hear about.
Yeah. All right. Well, thank you so much. We are now going to listen to Peter's first lecture on TIVA versus inhalation anesthesia. So we will go to our video now, and then we'll go straight into Anoushka and come back for panel discussion in just a moment.
So, my name is Peter. I've been invited to do this presentation in the EBPOM Congress. So thank you very much. This talk is about benefits of TIVA over inhalational anesthesia. So first, faculty disclosure. I've been invited by Covidian and Medtronic. So thank you very much for this invitation. My own disclaimer or conflict of interest is actually none, but I use both TIVA and volatile anesthetics on a regular basis. So it's not that I really oppose volatiles, but I think there's a lot of benefits in regards to TIVA. And also I'm a co-founder of the Safe Brain Initiative. It's a non-profit, research-driven program made to improve patient outcome and quality through non-invasive guideline and evidence-based preventive recommendations. And we use patient-reported outcome to optimize standard operating procedures in an open platform with special attention to perioperative neurocognitive disorder. So this is, of course, something that I'll use a little bit of time to present also during this talk, because I think one of the most important things is to document what you're doing to a patient and to improve on a daily clinical basis. So first, a little bit philosophy about our job as anesthetists. So what do we try to provide as anesthetists? I think this is a very important question to ask ourselves every time we go into the theater, because otherwise everything just becomes a daily routine without anything to improve. So first, it's about creating a safe environment for the patient. We also want to do a controlled nociception for the patients. And of course, because we cannot do surgery in a moving target, we have to provide immobility for the surgeon, and of course the suppression of unpleasant experience of surgery. So bridging what we try to provide for the patients is also what we want for the patient after surgery. And this is also something that we should continuously keep in mind. We want to have patients with acceptable pain. We want to have no nausea and vomiting. We want to have no P&D, so that is meaning awake patients, oriented patients, patients not hallucinating, and without impaired cognitive function, or at least as good as prior to surgery. And then, of course, and I know some of my colleagues is not really thinking this as important, but this is also about providing proper control of the risk of delirium. So having patients being able to see, hear, and vocalize and communicate, and of course with acceptable stress and anxiety level, and feeling well. This is also a weird question. It's a weird thing to take into consideration. Many people think, but these are human beings, so we have to make sure that our patients are feeling well. So coming to the essence of the talk is why to choose TIVA over volatiles. And first of all, I think most of all, especially as residents, have been discussing this about the cardioprotection of volatiles. But to my understanding, there's no real evidence. So I'm taking these two good, solid articles about the cardioprotection, and Landoni et al. Is doing this research in 19, examining 5,400 patients undergoing coronary artery bypass, and his conclusion was there's no difference in mortality. And the same with this, with Kwon, also from 19, myocardial injury after non-cardiac surgery, and he was doing 3,500 patients as well, and discovered that there was actually no difference in MINS. So there's no real evidence that cardioprotection is a part of being anesthetized with volatiles. So nausea and vomiting is, of course, a big issue about the well-being of our patients after surgery. And we all know this great article from Apfel from 12, where his conclusion was that volatiles is the strongest predictor of the anesthesia-related risk factors. And he was doing a meta-analysis of 7 studies with almost 60,000 patients, and there's no doubt volatile is a strong predictor of anesthesia. And Shireman did in 18, so that's a more recent study, the same conclusion with children in 9 RCTs. There's more risk of having nausea and vomiting if you're anesthetized with volatiles. So here's a really good reason why to use TIVA over volatiles. Same when it comes to the neurocognitive disorders, and I think most of us has experienced this with children, that when you do volatiles anesthetics, there's a lot of problems with the emergence delirium in children. And Chandler et al. Did in 13 a study where they saw there was more than double the risk of having emergence delirium if you're anesthetized with sevoflurane over TIVA. And in 18, Kikegaard et al. Did exactly the same findings, with this small exception that there's a even greater difference between the volatiles and TIVA. When it comes to my own daily routine, when I do the MRI of children, usually I actually give them a small dose of propofol before wakening the children up after they've been put to sleep. So definitely there's a big problem with the emergence delirium in children. So again, a good reason to use TIVA instead of using volatiles. So we know now that in children there's a problem with emergence delirium when it comes to volatiles. But what about in the perioperative setting for elderly people? And in this case, Miller and his group did, in collaboration with the Cochrane Library, do an examination of the research made for this. And he saw that in the TIVA group, there was fewer elderly people having perioperative neurocognitive disorders. Luckily, there was no difference in death and little to no difference in length of stay. But again, here there's issue with the neurocognitive disorder if you have been anesthetized with volatiles. So a lot of things are speaking into using TIVA over volatiles, but I really think that I need to state again that it's very important to take as much precautions to prevent any adverse effect for our patients after anesthesia. So back in 2016, we invented the Safe Brain Initiative, where we are doing a lot of bundles about optimizing the patients in specialty with the delirium postoperative, but also, of course, other neurocognitive disorders. But one thing here that I really want to state is that one of the things that really did a big difference for me as a doctor was to use the EEG-guided anesthesia and sedation, because this is where you really can make a big difference in the outcome for patients. And what I think is very good about TIVA is that you don't have to take into really consideration about the analgetic proportions of volatiles. So when I titrate my propofol, I do this regardless of the analgetic status of the patient. So I treat these two things completely as two different parameters. So every time I try to optimize the depth of sleep for the patient, I don't have to be worried that suddenly my patient will wake up and start moving around during surgery. But otherwise, it's a very good set of recommendations, and hopefully I'll get a possibility to dive deep into these during our discussion after the two talks. So what do I do? And this is what I think is the essence of this talk, is what I try to do that makes using TIVA interesting. First of all, I keep the patient's need in focus. I do the prophylactic measures as much as possible. Then I monitor the patient just like most of you do back home probably. And then I do the baseline outcome measurements of the patients. And if possible, do neuroaxial blocks or regional anesthesia. And otherwise I use continuous anesthesia, usually with remifentanil. And then we just start doing anesthesia. And as you might see, because we're using both nociception and processed EEG during anesthesia, I can start up with the rather low amounts of both propofol and remifentanil to evaluate how the patients are responding to the anesthesia. So this is both in regards to processed EEG, but also, of course, to either EMG signals. Then I do the induction. Either I give a small dose of bolus of remifentanil, otherwise I use fentanyl or sufentanil, and after this, again, a rather low dose of propofol. And this is where I think it's really interesting with the TIVA, because you know that propofol is only reacting on the GABA receptors in the cortex, thalamus, and pons. So in this way, you know that there's no analgetic proportions into it. So it's very stable and very excellent drug to make people fall asleep with. Then I titrate the propofol and opioids according to the processed EEG and, of course, other brain parameters. And this is also, again, you cannot solely use your confidence in the signals you're getting out. You have to think about all the other parameters as well. And then evaluate, interpret data during anesthesia, take timely actions. And then after, of course, you have to see what went good, what went bad with the patients. So at arrival at PACU, we reorient the patient as quick as possible. We give patients drinks and food. And then we do the post-op pros. Then we make sure that the patients evaluate us also, because this is a part of the Safe Brain Initiative bundle. So we have to make sure that the patients had the good experience during the time in the PACU and the theater and the pre-medication talks. And then, of course, we have to see, what did I learn from this case? What is the take-home message from every case? Otherwise, you won't be better yourself. And then, of course, because we have this very strong data set of quality data, then we're able to evaluate on the collective data, and if possible and necessary, of course, change the standard operating procedures every month and evaluate the following month. And again, I'll just show you shortly this case report form that we're using on all our patients. So we're using monitoring for pain, RAS, delirium, anxiety, stress, nausea, vomiting. There's a site B also, so there are more process parameters. But this gives us a very good idea of what is happening to the patient. So after we get the data in from the case report forms, we'll have all the data calculated and exposed in this dashboard, and this is really, really good tool for us to see what are we doing good and bad for our patients. And of course, if any one of you guys want to join in the SBI, this is what is available as a tool to optimize your cases. But on the left side, there's the average data on all our cases, and I've done a small calculation on the TIVA group on the right side. And I just want to show that the TIVA group is having less PNV than average. It's having less stress anxiety. It's having a little bit more delirium and a little bit more pain, but this is because the data on the left side is also including patients in axial blocks and regional anesthesia. So that might give some positive addings on the average. But I can at least say that TIVA patients are doing as good as the average patient in our setting. So this is the dashboard number 2, and the reason why I take this with is also because it's important for me as a doctor to be able to evaluate my patients in subgroups. So this is the female subgroup, and I just wanted to show that we can actually show in our own quality data that the female patients have a little bit more nausea and vomiting, they have more stress, more anxiety, they have a little bit more pain, and well, most probably the same amount of delirium. But it's really giving me a lot of opportunity to tune in on the different kind of procedures we have in the different cases. So the last 2 slides about our outcome is the delirium, applying TIVA, applying the process EEG, applying actually all of the SBI recommendations to the patients is giving us a great benefit when it comes to postoperative delirium. You can see that the amount of patients having delirium over time is down to 25% of what it was in the beginning in 2017 when we implemented the Safe Brain initiative. So this is really strong outcome data. And thirdly, about what I told in the beginning, that one of the biggest reasons why I think that this platform that we are doing ourselves and we are providing for anyone else that is interesting is that it's giving us the ability to change the procedures. So here in the end of September 2018, we changed our PNV prophylaxis recommendations, and you can see we almost half the amount of patients having nausea and vomiting after surgery. So to sum it up, I think in TIVA you have a superior way of doing anesthesia to most patients. You have 2 kind of drugs you're giving patients. You give them usually sedatives, and then you give them analgesics. Sometimes you also, of course, give them muscle relaxants. But when you look at the sedatives and you look at the way you're able to finely tune the amount of propofol given to patients using processed EEG, you have a really solid way of minimizing the side effects, especially when it comes to neurocognitive disorders, when it comes to emergence delirium, when it comes to PONV. So in this way, I think that the propofol affecting only the GABA inhibitory cells of the cortex, thalamus, and pons, it's a very strong agent, and as this is the case, I think this is superior to volatiles in most cases. So with this as being the first talk, I hope that we'll have a good basis for doing a good discussion afterwards. And again, a small commercial for the Safe Brain Initiative. Feel free to contact us, and then I'll see you live in a very short time. Bye.
Hi, my name is Anoushka Afonso, and it's my pleasure today to talk to you about inhalational over total IV anesthesia, some practice considerations and trends. I'm over at Memorial Sloan Kettering Cancer Center in New York City. So I'm going to talk to you a little bit about the 19th century British fairy tale. It's about Goldilocks, and it's about a little girl who finds a house in which 3 bears live. Each bear has its own preference for food, chairs, and beds. And after testing everything, Goldilocks decides that one is always too much in one extreme and the other is too much in the opposite extreme. And the whole concept of trying to find one that is just right. So this primary goal of finding the just right has been applied across a variety of disciplines such as economics, psychology, and even into the medical field. So finding the right amount can be applied to brain monitoring. You don't want too deep of an anesthetic, and you don't want too light. You want just the right amount. This chart represents a general association between clinical state and values. Process EEGs range from 0 to 100. We've been taught to keep the values 40 to 60, indicating an appropriate level of anesthesia. So this is a slide that looks at whole brain glucose metabolism as measured from PET scans. And as you can see, as you go across the slide to the right, there's a significant correlation between decreasing brain metabolic rate and increasing anesthetic effect. What are some of the advantages of inhalational agents? This is a little bit debatable. It's cheaper. It's titratable. What does this mean? Gases have a low blood gas solubility, means it takes effect quickly. It can be easily titratable, easily changed. A lot of anesthetists or anesthesiologists, depending on which side of the Atlantic Ocean you're in, have greater familiarity. There's no injection pain, reduced bacterial contamination, and it's a great option, especially in those difficult situations where you have a difficult IV access. So there is increasing evidence that anesthetic agents can interact with the underlying pathomechanisms of ischemia reperfusion injury and be involved with myocardial protection, which is especially important in cardiac surgery. In fact, a recent New England Journal article from the Myriad Group showed no difference in 1-year mortality after elective CABG in over 5,000 patients. So there was no benefit of actually TIVA use in mortality outcome. In fact, most cardiac surgeries are still done under inhalational agents. This was another study where they looked at the effect of BIS in inhaled agents consumption in older adults. There were no differences in preoperative between the groups, ASA, age, BMI, etc. But what they did find was the following. There was a reduction in inhalational anesthetic exposure by 40%. So this was quite interesting. Those that had BIS had less inhaled anesthetic consumption. In addition, the time to eye opening, extubation, and ready to shift to the recovery room was much shorter, all significant in the BIS group. What was really interesting about this is the fact that you could see all of this, and this is important in terms of from an enhanced recovery perspective. So my hat as enhanced recovery, I really want to see these patients recover in a faster, more quality manner. This is another study that looked at the effects of BIS monitoring during colon cancer surgery in older patients. They looked at 41 patients in the BIS group and about 40 patients in the non-BIS group. So they just underwent standard intraoperative hemodynamic monitoring. Though in the BIS group, they had an adjustment of anesthesia to maintain a BIS value between 40 and 60. So what happened here is they did a standardized attention network test, and it measures alert, orienting, and executive functions. And so they did this preoperatively. They did this on post-op day 1 and post-op day 5, and using this standardized measure. And what they found were that there was no difference between the two groups preoperatively. However, this is what I find very interesting. In post-op day 5, they found that the alert and orienting functions recovered much faster in the group that was monitored with BIS, but remained impaired in the non-BIS group, so no EEG monitoring. So earlier, having these patients alert and oriented 5 days after surgery is in line with some of our efforts in the enhanced recovery program. We want our patients to have an earlier recovery. We want our patients to be on the road to recovery. That creates value. But what is our current practice? I know this is a global conference, but I just wanted to bring in some light into some practice variations depending on what country you live in and what country you practice in. We use a lot more inhalational anesthesia in the United States, but I do want to look over a few of the studies that were sent out. This first study was sent over email to a few international professional anesthesia societies based in Hong Kong, Australia, New Zealand, UK, Ireland. And the purpose of the study was to look at factors influencing the use of propofol-based total IV anesthesia. They looked at 763 survey responses, and they stratified them according to the TIVA use. And as you can see, quite a diverse international group here. And I do want you to pay attention to this. In real life, there are many reasons for not using TIVA, and often it doesn't have anything to do with science, logistical reasons. And the most common logistical reasons were it required additional effort. There was unavailability of depth of anesthesia monitoring. It was expensive. There was no target controlled infusion or TCI pumps. Clinical reasons included lack of real-time propofol monitoring, no IV access, and it was very difficult to predict wake-up times and titrate dosages. This was another study based out of Australia and New Zealand. And what they did, they surveyed 275 anesthesiologists, and what they found was, for the most part, those that used TIVA for over 50% of the cases comprised only of 18%. Those that used TIVA for up to 20% of the time comprised of 46%. And there were many barriers to use of TIVA. Although the survey respondents say that they didn't use TIVA because it wasn't easy to titrate, there was more equipment failure, there was a longer setup time. It was interesting that those that thought TIVA was associated with less cancer recurrence was only 43%, and 46% thought there was no difference at all. And only 29% of the respondents say that they would use TIVA often or very often for cancer surgery. But does this translate into a meaningful outcome? This is a big study where they looked at long-term survival in solid tumors, and this retrospective analysis looked at association of anesthetic technique with long-term survival in a comprehensive cancer center over 3 years, and after propensity matching, they found that the hazard ratios for volatile anesthetics was 1.46. And so it really goes a step back, and this was on the cover of the Anesthesiology journal. Does anesthetic approach really matter? Does it matter? We don't know. In fact, this was a study out of Germany where they looked at newly diagnosed glioblastoma patients, and after propensity matching, 52 remained in the TIVA group and 92 in the inhalational, and they found there was no difference. There was no difference whatsoever between inhalational or TIVA. This was another single center that showed, lo and behold, no association, and this they used the subtype of breast cancer, if that patient had any postoperative ketorolac or anesthetic time or transfusion. They had propensity match variables for all of those, and they found no association. This was the most recent meta-analysis this year, which looked at anesthesia and long-term oncological outcomes. And so there's no difference in recurrence-free, as you can see here. Slightly better with TIVA in the overall survival, but large-scale, high-quality RCTs are warranted. So we do see a lot of conflicting evidence. There's a lot of heterogeneity. It's limited data out there, but we are awaiting results from large ongoing international studies out there in terms of getting an answer about this topic. This is a joint statement from ACER, American Society of Enhanced Recovery, and POCI, the Perioperative Quality Initiative Joint Consensus. And it's a statement about the role of neuromonitoring in perioperative outcomes. And this was published in 2020. It was a meta-analysis of about 15 trials. What was interesting is they recommended use of process EEGs to reduce the risk of awareness with recall receiving TIVA during general anesthesia. It's a strong recommendation, albeit a grade C evidence. And how does this translate to my experience at Memorial Sloan Kettering? So we use TIVA for PONV, post-op nausea, vomiting concerns, especially in our breast and GYN cancer surgeries. So, and if so, we always use EEG monitoring for those in all the TIVA cases. I use it on my older patients, my frail patients. I use it in surgical complex cases with increased bleeding, volume shifts where I anticipate a lot of vasopressor use. So this slide shows ovarian cancer debulking surgeries at Memorial Sloan Kettering. Most of them are done under inhalational anesthesia. And as you can see in the yellow is the proportion of cases that we have with brain monitoring. We have a larger proportion over the last few years, and this is our clinical practice. So in addition to the hemodynamic variables, we also monitor the brain that gives us the real-time what's happening to the patients on the operating room table. I may have mentioned TCI, target controlled infusion pumps. I have no experience with this whatsoever, because it doesn't exist here as of yet. So as part of the anesthesia care team, our sphere of influence goes beyond the OR. The focus should always be on the patients we serve to give them the best possible care. So it's important to fully appreciate the applications, limitations, especially real-world practice considerations for use of processed EEGs, and also understand the barriers and facilitators there are worldwide as we try our best to optimize patient care. Thank you so much. It was a pleasure to talk to you.
All right. Thank you so much for those phenomenal presentations. We're going to have Monty Mythen join us here in just a little bit. He's going to be monitoring our Slido questions for us, so we'll be sure to get to those. All right. Well, again, fantastic presentations from Peter and Anoushka. Peter, I'm going to start with you first. You told us about your practice, and it sounds very familiar to me. I'm a nurse anesthetist here in the States, but I want to make sure we level set and make sure everyone's on the same page when it comes to what TIVA is, total IV anesthesia. So can you, again, just refresh us on what TIVA really means?
In my opinion, it means that what you're using is something you are giving intravenously. So it's not something that you supply with some kind of inhalational agents. So in my point of view, when I use propofol, remifentanil, or rocuronium, for example, this is something that I address as being TIVA.
And do you do any other multimodal analgesia or medications that you add to TIVA, such as dexmedetomidine or any other types of infusions?
In rare cases, we also use lignocaine, we use dexmedetomidine, we use ketamine. And then, of course, if you've got some kind of problems with the depth of anesthesia, or you have got problems with the analgesia, then you can add also, of course, volatiles in addition to the TIVA if you need to. But I would say that at least in 90 of the cases, it can be done with TIVA alone.
And do you feel that TIVA is pretty fairly titratable and you can titrate pretty easily to the patient?
I absolutely agree with Dr. Afonso that Of course, when you have given something inside a vein, then it's not possible to get it out of there again. So it's whenever you do empty some kind of syringes, then you're doomed. You have to accept the consequences of your actions. But otherwise, I think it's extremely titrable, especially with the new kinds of monitoring system we're getting with nociception and processed EEG. I think the risk of overdosing patients today are almost zero when you see it compared to 10 years ago.
Yeah. And you use, as a standard for your practice, you use processed EEG on all your TIVA patients. Is that correct?
No, we use it on all our patients, even the patients
on
we
all
sedate
of your
over
patients.
the phone. Yes, exactly.
Okay. That's good.
I see
all
no
right.
excuse not to do it, because there's also evidence that even patients having sedation, light sedations, if they get too much, they'll have side effects afterwards. So we actually use it on all our patients.
Yeah. All right. And Afonso, does all this sound familiar to you? Is this pretty much jive with what you're doing?
This does sound familiar. I especially agree with Peter's definition of total IV anesthesia. In terms of our practice, we do use propofol infusions. With our bigger cases, we also use dexmedetomidine infusions to supplement. You talked a little bit about multimodal analgesia. We have a lot of enhanced recovery programs running. And as such, we try to use a lot of different modalities, from regional anesthesia to other non-opioid infusions of medications, in addition to our infusions, our total IV anesthesia. So, and then in terms of what patient populations where I use my TIVA, we use TIVAs in other neuro cases. We use a fair amount of TIVA in our ambulatory surgical centers. So this is a freestanding ambulatory surgical center where we do robotic GYN procedures, mastectomies. We have a big PONV, post-op nausea vomiting scoring system. So anyone scoring higher 3-4 will get a TIVA. And anyone having any TIVA, whether it's at the main hospital, at the ambulatory surgical center, will get processed EEG brain monitoring. That is, we monitor everyone who is getting TIVA with these processed EEG monitors. That being said, I do also use processed EEGs for my general inhalational cases, which we do a fair amount of as well, especially if it's a complex patient, complex surgery. I mentioned in one of my slides, an older patient, frail patients, patients that I know I'm going to be transfusing a lot of fluid shifts and vasopressor use, that I may have to titrate down my anesthetics, then we will use processed EEGs.
Yeah. One question before we go on. When it comes to, you talked about using processed EEG or BIS for the majority of your patients. Let's talk about standardization of care. Is it a standard practice, and is it a standard by recommended guidelines to use processed EEG for TIVA in the U.S.? And I'll ask you first. Peter, go ahead.
No. I was just about to say that. Well, in my facility, my department, it is, but it's not at a standard operating procedure in all of Denmark, because there's always, and I think still there's the question about the expenses. Is it worthwhile the extra cost for each case? And I would state clearly, without a doubt, of course it is, because using the kind of electrodes you're using is very cheap compared to how much you use on patient having delirium or other side effects, because it'll increase length of stay, it'll increase especially downstream costs of the patient. So using these extra $10, $20, $30, whatever it is, it's absolutely it's a good investment in your patient.
And Anoushka, how about you? What is the current in the U.S.?
So there is a lack of standardization among many things in the United States. And I think use of processed EEGs, BIS, is definitely on there. As far as my department, we do use processed EEGs BIS monitoring for our TIVA on all our TIVA cases. And there has been an increase in using process EEGs, BIS monitoring on some of our high-risk patients, complex patients, as I mentioned before. But there is, Desiree, I agree with you, there is no standardization, which has been a problem.
Yeah. Well, it is. And what about residents and new anesthesia providers coming out? I've noticed that although they may be teaching this in our programs, that new folks, new anesthesia providers are not necessarily using this for TIVA. And I can't imagine doing a case without processed EEG, a TIVA case. But Anoushka, what about you here in the States?
It's very institutional dependent. And I think that goes back to the culture. And the culture goes back to a culture of the institution and a culture of regional variations. And I think in a lot of the survey studies that were done, you can see that variation from the United States, from Australia, New Zealand, and even talking to some of my colleagues in Europe. I mean, you guys use a far higher amount of TIVA than we do in the United States.
I think now that we know that so many guidelines, especially for the big societies, the European Society, for example, they're recommending this by a grade A. So at least in the Western part of the world, I think it would be unethical not to do it.
All right. Well, there are some questions coming in, and I really want to make sure that we get to our Slido questions. Let's just go ahead and start answering. The first question's been voted up 8 times. Why do you not use TIVA with TCI in the USA? Anoushka, I'm going to let you take that one.
All right. So we don't use TIVA with TCI pumps in the United States because of one reason. It's not FDA approved. So we're not allowed to use it. I've never used it before. I don't have any experience in using TCI pumps because it's not allowed in the United States.
Yeah. And the next one is on that point. Thank you. Great talks to Dr. Afonso. If there are no TCI pumps in your experience, what do you use to deliver TIVA anesthesia in your practice?
So I think that we use just the basic pumps and we, titrate it accordingly, and we use the process EEGs to do so. And I think that actually has been a big barrier in terms of ease of use. A lot of survey studies that we looked at, they looked at ease of use, how easy was the setup, how easy was it to titrate, and those were some of the barriers to use of TIVA. It's so much easier to just turn up an inhalational agent versus in the United States, we're setting up the pumps, and it's a little bit more, time consuming doing that. And, the people in the room, it's just not as easy. So.
Yeah. And TCI, just for our viewers out there who may not be familiar with it, because I wasn't when we first started talking about this, target controlled infusion pumps, correct? Yeah.
Correct, which I have no experience in.
Peter, have you had any experience with TCI pumps?
Yes, I have, but we don't use them on a regular basis in my facility right now. Okay. It's a good way of getting adjusted to how you use TIVA, because the pumps calculate for you what amount you have to give to the patient to get a steady state. But otherwise, I won't say that is a cutoff when it comes to using TIVA. It's about using it, getting used to it, just like you use any other agent that you have to get accomplished to it.
Yeah. I think in the States, we're so used to looking at an anesthesia machine that has MAC values and, gives you some kind of targets that way. With TIVA, I would assume that that's kind of what target controlled infusion pumps do for you. But I use TIVA every day in my practice and go off, processed EEG whenever I do it. So next question, what differences do you find in vasopressor requirements or effect on MAP when using TIVA or inhalation anesthesia?
I don't see there's a difference when it comes to either processed EEG or anything else when it comes to vasopressors. So I don't see this as a problem when it comes to doing anesthesia. We're using both processed EEG and the level of depth of anesthesia in the same way as with or without vasopressors.
Mm-hmm. Anoushka, you do a lot of both. Do you find a difference in the amount of vasopressors that you're giving to patients?
I don't. I think I put it in one of my slides because just to reiterate those big complex cases where we might have to turn down the level of anesthesia a little bit lower, just so we maintain our blood pressure and hemodynamics. It's always great to have the process EEGs there because, I want to make sure I can, that they're not aware and not remembering anything and reduce the incidence of awareness there. So I want to make sure that I'm cognizant of that. But I don't feel like the vasopressors itself has an impact on the process EEGs.
Yeah, and in my personal practice, it's not between TIVA and anesthesia and inhalation. It's between biz and no biz. Usually, I can give a lot less because you're titrating more with your gas. All right, next question.
But I think one comment on this vasopressors also, because I think many people are afraid of having awareness in patients. So we have a long history of overdosing our patient with both sedatives and analgesics. So I think this is a problem, and we have to look into this because it's not that either propofol or remifentanil or norepinephrine is like vitamins for the patients. So we should consider using less.
Yeah, I know it's really interesting. It seems like everybody's carrying around a stick of vasopressor just to treat everyone, and that's first line before actually titrating. Anoushka, do you find that?
I find that very much so. And I do agree with Peter. You mentioned just using less. I think that also plays in part with our older patient population. Using less anesthesia is a good thing for that patient population. I've noticed an increased recovery time. We mentioned some of the studies in terms of the attention network, validated studies that they have out there. But we are using, less than we would normally use without process EEG monitoring in terms of anesthesia. And that's been measured in a few studies. And I've seen it in my clinical practice as well.
Yeah, I found that study very interesting. A couple questions here. Do you find that BIS for inhalation anesthesia matches the MAC targets for those patients? If there is a wide variation, should it be mandatory to use both BIS and MAC monitoring for inhalation anesthesia? Anoushka, I'll go to you on that one first.
So is there a variation? I think MAC values are, the concentration and vapor in your lung where it's needed to prevent against 50% movement in about 50%. So MAC values are, dependent on so many factors. We know that MAC decreases by 6% per decade, regardless of the volatile anesthetics. There's so many different factors that come into play. I recommend using process EEGs and MAC and your hemodynamics. I'm looking at trends. It's not one single number that's going to give me the answer to everything. It's looking at the patient on the OR, what's happening in the OR, what's happening when I'm looking at the monitors. You can have all the monitors, but if you don't know what to do with it, then you're stuck in a bad place. But it's got to give you the information. You've got to also see real time what's happening on the operating room table.
Yeah. Peter, did you have a quick comment on that one?
Yeah, I think that when you have, especially in the very old patients, only using the MAC will give you actually no clue on how the depth of sleep is. So this is just like shooting into the blind.
Fair point. Well, let's try and get through some of these questions kind of rapid fire. To Peter, do you find less cognitive dysfunction in elderly patients with your TIVA practice?
Absolutely. With a double exclamation marks afterwards. big, really major changes, and we'll go down very low to the elderly people, maybe down to 2 or 3 in the milligrams of kilo per hour. So it's a very low dosage, and I've never done this in my whole career before I started using process EEG. It's a major difference.
And do you screen for awareness post-operatively, Peter?
Yes.
Okay. And then the next question, you mentioned a propensity matching in one of the studies. Can you explain more about what that means? Anoushka, I think was that for one of your studies?
It's probably the Korean breast cancer study where they compared volatile to TIVA, and they wanted to make sure that both the patients were matched in terms of ASA, breast cancer subtype, because a more recent study came out where they looked at a heterogeneity of breast cancer subtypes, and some were more immunogenic, meaning that they had more of the immune system regulations in exposure to inhalational agents. So in answer to your question, they use propensity matching to making sure that the patients are leveled and appropriately matched to say what they're going to say in the study if TIVA or inhalational were a better option for anesthesia. In that case, there was no difference in outcomes, oncological outcomes with that after propensity matching.
Great, thank you. All anesthetics affect the brain, so why is it that we are so resistant to monitoring the brain in every case, regardless of anesthetic technique? Makes no sense to deny this level of monitoring to patients because they have gas on. I think we probably would all say yes. Agree.
Yes.
All right, does a BIS of 40, emphatically, does a BIS of 40 have the same meaning on every patient? If not, how do you differentiate it? Peter, I'm going to go to you on this one.
That's a very good question, and I'm not quite sure if I'm able to answer it, but my response would be yes, I think so. But it's a calculated value, and there are so many things to take into consideration, and I don't know the matrix how the BIS is calculated. But I would say that, you know, if I evaluate patients post-operatively, I would say that if patients have been lying on a BIS value of 40, they'll have the same no memories of any kind of awareness during anesthesia. So I would say yes.
Okay. Next question. Are you using density spectral array to titrate your analgesia? And you are doing that. You're using nociception
I am, of course.
Monitoring. Yeah.
Yeah, we do.
Okay.
We do both. But DSA is also very much about, you know, seeing the evaluation of anesthesia and being able to address a patient if there's been a problem in the DSA curves or the CEF or the MF or whatever. So it's also about, you know, seeing in the entire period of surgery how the responses to the anesthesia was for the patients. But I use very much the raw EEG when I evaluate my patients.
Peter, you briefly showed a slide illustrating your data collection sheet. Is this something we can access on the SBI website?
Yes, it is. And I think for most of our colleagues, it will be very important also to measure your own outcomes. How many of us is actually doing this on all our patients, making sure to screen for PND, for delirium, for these factors. So this is, I think of course, it's not my idea. My head of research, Finn Ratke, who's a professor in my facility, is, of course, the brain behind the Safe Brain Initiative. But this is what we have to do, all of us, to make sure that all our patients are screened afterwards, so we can take the precautions and do the communication with the patient afterwards if something went wrong. But we have to measure it, of course.
I think that's a really important point that Peter mentioned, is looking at your own data, auditing your data, looking at compliance, because you can't make statements about your own institution and without looking at the data to see if you did what you did really mattered. And if not, then, you know, make a difference.
Yeah. Well, I think, you know, guys, we're up on time. Monty, I know we didn't bring you in, but you've been behind the scenes monitoring for us. So if you're there, thank you very, very much for helping us out. There he is in the studio in London. So good to see you, Monty.
Great to see you.
Anoushka and Peter, thank you so much for fabulous presentations and conversations.
Thank you very much.
Thank you so much.
Yes. Yeah, and intriguing conversation. And thanks to the audience for asking questions on Slido. There were some great ones there. You know, if you felt like that the presentations and the experience today during this lunchtime session made an impact and will make an impact on your practice, let us know. You know, you can comment in Slido or to us at the EBPOM at EBPOM, we'd love to know. And if you missed any of the presentations, no worries. We're going to be streaming this later on the TopMedTalk platform later this evening and afternoon. And you can also find them on the EBPOM platform, our carbon-free conference center after the show. Be sure to check out the TopMedTalk stage today because it is Medtronic Day, and we have other wonderful conversations from Dr. Sam Ajizian and Dr. Ross Hoffmeyer from South Africa. We're going to be talking about video laryngoscopy later today, so be sure to check that out during the tea break. Thanks again so much to our sponsor, Medtronic. Be sure to check out their booth in the exhibit area as well. Thanks so much for watching today. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.